Next speaker, Dr. Rani Balamurali, to speak on Phacoemulsification on cataracts in induced glaucomas.
Good morning, all. I don't know how much time I have to for this presentation. So this is treatment of surgical treatment of lens-induced glaucomas. So these are the common causes of lens-induced glaucomas. It's a secondary glaucoma where the crystalline lens contributes to the increase in IOP. There can be a neglected intumescent cataract, dislocated lens causing pupillary block, phacolytic lens material causing lens particle glaucoma, and phacoantigenic glaucoma. The mechanism of phacomorphic is a secondary angle closure one. Then clinical features are similar to angle closure glaucoma with severe pain, headache, blurred vision, and slit lamp examination will show a shallow anterior chamber, and gonioscopically the angle will be closed. You have to lower the intraocular pressure with aqueous suppressant and hyperosmotic agents. Do laser iridotomy for rapid control of IOP, and it gives you space in the anterior chamber during cataract extraction. Surgery can be done under topical, subtenons, or perimulbar block. You have to give a gentle massage if the angle is too shallow. You can give hyperosmotic agents, or both cohesive and dispersive OVDs should be used. So the studies show that pars plana vitrectomy is also helpful in getting a deeper anterior chamber as well as perimulbar block. So this is a case of phacoemorphic glaucoma managed with the IV mannitol and subtenonous anesthesia. The lens is too tense, the capsule. You can make multiple punctures in the anterior capsule and let out the material inside the capsule to reduce the intracapsular tension. So you can aspirate the content as well as massage it out. Now you can easily conduct the capsulotomy rexis without the fear of an extending or Argentinian flag sign. You can complete the phacoemulsification. As you see, the capsulotomy is very easily performed and phacoemulsification is completed. So next is a case of phacoemorphic glaucoma with multiple posterior synechiae. So you have to release the synechiae with the help of visco as well as forceps. Now we have to insert a BHEX ring in this case because of the small pupil. All the flanges are inserted and you get a good hexagonal pupil. And you can complete the capsulotomy and complete the phacoemulsification. So next is a phacoemorphic glaucoma where you can see the synechiae, there is a good dilated pupil, but the synechiae is in the periphery. So you can do the capsulotomy is done in the same fashion with multiple punctures and aspiration of the contents, and then you can do the peripheral phacoemulsification, but the synechiae is not released till the end of the surgery because it gives you a good support for pulling the capsule as well as during your phacoemulsification. So this is another case where you are doing a small incision cataract surgery. Here in the incision is too small, 3.5 to 4 mm incision is made. And once you finish the capsulotomy, you are delivering the lens into the sulcus, and with the help of a pre-chop, it is chopped and the pieces are delivered out with the help of a vectis. You can place a foldable IOL in this case through the small incision tunnel. So the lens particle glaucoma is caused by the grossly disrupted capsule and liberated lens fragments in the anterior chamber. It may occur after cataract surgery, trauma in yak capsulotomy. The clinical features are similar, but inflammatory component is more. You need more steroids, cycloplegics, and aqueous suppressants. Phacolytic glaucoma is quite common. It is because of the obstruction of trabecular meshwork with macrophages, lens material, and high molecular weight lens protein. And the clinical features are similar. You get microcystic corneal edema, deep anterior chamber, AC is open with pseudo-hypopine. The treatment is also similar, and the definite treatment is cataract extraction. So this is a you can control the inflammation and you get a clear cornea and a white eye. Then you do the surgery. So we have planned a phacoemulsification for this patient, and once we proceed for anterior capsulotomy, you can see the zonules are too lax and it's difficult to perform the anterior capsulotomy. So the capsule is cut with vanas and the lens is delivered into the anterior chamber and SAC is performed. When you deliver the lens into the anterior chamber, use 2 instruments so that the zonules are not further weakened. So convert into an SICS and deliver the lens. Since the zonule is too lax, you can see a little liquid cortex in the vitreous also. If it's a small amount of cortex, you can retain the cortex there and give more steroids. So in this case, 3-piece lens is sutured into the eye with the 10-0 Prolene suture, and the surgery is done. So this is a this is faculty glaucoma, which is medically managed, and we are now doing planning and SICS. Here also the capsule is, the zonules are 2 lakhs, and the capsulotomy is not, CCC is not done. We have done cut the anterior capsule with Vanas. Now the lens is delivered with the help of 2 instruments into the anterior chamber. You can see a lot of liquefied lens material in the vitreous. So this has to be removed because it will cause a lot of inflammation post-operatively. So once you put the IUL and suture it into the iris, and then you do with the help of an anterior vitrectomy, you can make a posterior capsulotomy and remove the vitreous along with the remove the lens mat along with the vitreous cutter. So this is another case of phacolytic glaucoma, which is medically managed. Cortex is in the anterior chamber is aspirated. Here we could perform a CCC. A grade 4 nucleus is there, and it is prolapsed into the anterior chamber, and an IOL scaffolding is done. This will protect the zonules as well as the posterior capsule. You can do a pre-chopping in the anterior chamber and remove the fragments with the help of phaco, and the surgery is done. This is another case of phacolytic glaucoma, and we have now planned a small incision cataract surgery. Just like any other case, we could get a good CCC. So lens is delivered into the anterior chamber, and with the help of vectors, it is delivered out. So all these cases, there will be a lot of inflammation post-operatively. You have to manage with steroids, and the duration and frequency should be more, and you have to follow up. Most of the glaucoma will be controlled, more than 19% of the glaucoma will be controlled with the cataract surgery. But after post-operatively, you have to follow up the patient for persistence of raised intraocular pressure. Thank you.
Thank you, Rani Madam, for those practical tips and beautiful videos.